including Mr. Jones, say, "Well, no, doctor, because if you do that, you're going to mess up my car." And I say, "Well, why do you think you can put bad things in your body and get good results when I can't put bad things in your car and get good results either?" And now the word picture helps them get inside and understand things better. I will explain to them that diabetes is much like marriage. Faithfulness, commitment, till death do you part. If you're faithful in marriage and committed till death do you part, you generally have a much better outcome in marriage than if you're not faithful and not committed. Invariably, when I explain that to a patient, they get it, they understand, but they come back in a month or two and they tell me, "Dr. Fillingham, I did wonderful with my diet last month. I only cheated on my diet 3 times. I'll usually look the patient in the eye and say, "Mr. Jones, I did wonderful in my marriage last month too. I only cheated on my wife 3 times. Now, obviously, I didn't cheat on my wife 3 times, but I'm trying to get a point across. Diabetes is like marriage, faithfulness, commitment, till death do you part." When I say I did wonderful in my marriage, I only cheated on my wife 3 times, Mr. Jones would look with disgust, and rightfully so. He's getting the message. Cheating on your wife 3 times, not acceptable. Cheating on your diet 3 times, not acceptable. It's a word picture. It's a memory for a lifetime. Learn your communication skills and how you can get your patients to understanding this disease and becoming successful. You know, Dan Rader's way back in 2000 in New England Journal of Medicine was saying we need to look further past what we're doing right now, just looking at the lipids, just looking at blood pressure, just looking at smoking. There's got to be much more we can do because so many of our patients are still having events and we're not doing anything that makes meaningful, significant difference. You now have advanced biomarkers. You now have a better understanding of the physiology of disease. You now know more things to do on your physical exam to make a difference. You know more things to ask in your history. You can beat this disease if you extend your net wider. You look at these additional risk factors and go after them with a passion. Now let's start with the lipids though, since that seems to be the area that most physicians lean most heavily when they first start their physical exams and cardiovascular workup on their patients. Now even in looking at lipids, we've got a broken system again, in the sense we're looking at the wrong things. For years, primary care physicians, cardiologists, neurologists have been looking at lipid profiles and hanging their hat on important information from there to decide when and when not to treat for this lipid abnormality problem. They've been relying primarily on LDL-C, which is LDL cholesterol. The C stands for cholesterol. Now, if you look at very important data from NIH, you'll find out that approximately 64% of Americans over the age of 20 are insulin resistant. Now, as you understand the physiology behind insulin resistance and what goes on in that LDL cholesterol, you'll find out that the longer a person is insulin resistant, the less cholesterol they have in LDL-C, because that cholesterol leaves the LDL-C lipoprotein and it is replaced with triglycerides. But the measurement is not of the lipoprotein LDL, it's the measurement of the cholesterol in the lipoprotein, because that's what the LDL-C stands for. Well, if you've got a patient that's only been insulin resistant maybe 6 months or a year, it might not be a major disparity. But now this patient that's been insulin resistant for 5 years, 8 years, 12 years, now the LDL-C is going down because the cholesterol level within that LDL-C has significantly shrunk over the years, replaced with triglycerides. You see a low level of LDL-C such as 58, 66, and you think, oh my goodness, this patient's doing wonderful. But then you get an advanced marker like an LDL-P or an ApoB, which looks specifically at this lipoprotein. And you see that the particle number is rather high, but the LDL-C is rather low. Which one's telling the truth? It's the particle number, it's the ApoB, because these are actually measuring specific amounts of the LDL circulating in the serum of the blood that was just drawn, representative of how much bad fat is in that patient. Therefore, doctors just doing standard lipid profiles get deceived by thinking their patients are doing better than they are. The patients get told they're doing well in their physical exam. You're healthy as a horse. And then a month later, they show up with a heart attack or stroke, and they ask their ER doctor the same question they asked me for years. What did my doctor miss? We've got to extend our net further and begin looking at these more advanced markers. If you're looking at these traditional markers versus the advanced ones, you're so many times going to be misled. The traditional one would say, for instance, in this case, that this patient's LDL-C of 117 is near optimal. Now, if you say a person has near optimal LDL-C, you're suggesting this patient might need a little tweaking on their diet, might need to improve their exercise a little, but certainly not needing medication. But then you look at this advanced lipoprotein profile, and they're in the highest risk category that exists for LDL. They're in the greater than 95th percentile. So which one's right? Near optimal? 95th percentile worst cholesterol is the LDL-P and the ApoB. Thus, we have to cast the net wider and look at these more advanced profiles. If you're assessing the patient's diet, historically we could look at a lipid profile and know when the HDL is decreasing and the triglycerides are increasing, a patient is developing insulin resistance. Those are important markers. HDL, for instance, becomes a lesser and lesser number because as the cholesterol leaves the HDL and is replaced by triglyceride, the longer a patient is insulin resistant, the HDL becomes smaller, 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 smaller. It is the smallest of the lipoproteins, and eventually it filters out through the kidneys into the urine, and you urinate this HDL product out in your urination. Now, that being the case, the HDL levels shrink because you're eliminating them through your urinary system. If you are less insulin resistant, if you turn that genetic expression off, it would stand to reason. You're going to put the cholesterol back in the HDL, and it becomes a bigger and bigger HDL lipoprotein because the cholesterol going back in, triglyceride going out. Now you'll start preserving your HDL, and there is some belief that this could have a protective mechanism in certain facets of the HDL. Certainly more studies need to be done, but probably at least a factor in helping with plaque regression or removal. One of the most sensitive ways to measure carbohydrate intake is the measurement of the small dense LDL. Now, why is it important that you be measuring carbohydrate intake? It's because you have three food products: fat, carbohydrate, protein, but carbohydrates are the poison of these patients with insulin resistance. Now, if 64% of adults over the age of 20 are insulin resistant, this is an important parameter. I hope you'll take extra care to listen to what I'm about to say. When a person overeats carbohydrates, the first thing that's beginning to happen is the liver starts synthesizing bad fat, not for an hour or two, but for 4 days. While this synthesis is occurring of bad fat, smaller, more dense LDL lipoproteins, there's also an inflammatory response for 4 days that is distributed from the liver. The pancreas has to deal with this fatty influx, and we've got now a pancreatic inflammatory response. There are free fatty acids that are circulating, and the intra-abdominal fat has to respond to this circulating free fatty acids. It also has a 4-day inflammatory response. So let's play this back. When you exceed your capacity for carbohydrate metabolism with food intake or drink intake, you create an inflammatory response from the liver, pancreas, intra-abdominal fat cells for 4 days. I personally believe that's the number one reason we have so much cardiovascular disease in America. Years ago, I studied patients in my office to find out where the cutoff is. How many carbs can a person eat before they flip the switch in the liver and start this liver, pancreas, fat cell inflammatory response? And what I found out is when a patient that was insulin resistant ate more than 25 grams of carbs, they flipped the switch. Thus, from that point forward, when my patients were identified as patients with insulin resistance, I kept their carbohydrate level tightly controlled. 25 grams of carbs every 4 hours is a limitation. That means they could have 25 grams in the morning in a 4-hour period. They could have another 25 grams in the next 4-hour period, the next 4-hour period, next 4-hour period. And every 4-hour period, even if they woke up in the middle of the night, it didn't actually seem to aggravate them because they could metabolize this. But the body is like a glass. If you had a 10-ounce glass here and a gallon pitcher in this other arm, and you were trying to take that 1 gallon of grape juice and pour into the 10 ounce of glass, you know once you got to 10 ounces, you better stop because that's the capacity of the glass. But if I were to try to take the entire gallon of that grape juice, it would spill over because that 10 ounce glass could not possibly hold a gallon. What if I did that 20 times in a row? Is it going to get any better? And the answer is obviously no. What if I eat 50 grams of carbs this meal, do it again tomorrow and the next day? Am I going to get conditioned this and make it better? No. Because a 10 ounce glass is a 10 ounce glass, a 25 gram container for carbohydrates, which is what an insulin resistant body is a 25 gram container. Now, as you become less and less insulin resistant, you will increase your carbohydrate tolerance, and we'll talk more about that at a later moment. I studied a handful of normal patients, and it appeared that somewhere in the 90 gram carbs level is where a person with no insulin resistance has their maximum carb intake. Now, where does that become important? Well, you see, even if you're not insulin resistant, you can still flip this switch in your liver, pancreas, and fat cells by overeating more than 90 grams of carbs. How would you do that? You go to a fast food restaurant, you have a sandwich, French fries, and a drink with sugar. You could easily get 125 to 150 grams of carbs through that mechanism. That would be past the 90 gram capacity. You just flip the switch, so even a non-insulin resistant patient could have the same dilemma, create the same inflammatory response, create the same plaque in their arteries, create the same ability to have plaque rupture. Thus, measuring and looking at that small dense LDL is important. Now, what I noticed from those food diaries and what was going on with these measurements of lab parameters when I was looking at nearly 1,000 patients is that we got a patient that had a small dense LDL of 25. They were usually overeating carbohydrates about 3 to 5 times per week. If they had a small dense LDL of 35, they were usually overeating carbs between 12 and 15 times per week. If they had a small dense LDL of 50, like you'll see on this particular patient showing on the slide, that patient is probably overeating carbohydrates 21 times or more per week. If you were only eating 3 times per day, and you were overeating carbs 21 times per week, that would suggest that almost every meal is horrible in flipping the switch. Teach your patients about that switch and how to flip it. Now, you see the ApoB and the LDLP are very high in this patient who has this very elevated small dense LDL from overeating carbs. Let's talk about that briefly. Where do you get bad fat in your body? Only 2 places. Bad fat comes from what you absorb through your intestines as you eat products that contain high levels of saturated fat. Bad fat enters your circulation through what the liver manufactures, and that process is stimulated by your overeating of carbohydrates. Average patient has about 70% of their bad fat in their circulation from what the liver produces, 30% from what they absorb through their intestinal tract. Now, this can be varied. If you're an extremely high carbohydrate eater, you could be an 85% liver manufacturer, 15% what you absorb through the intestines. Now, in this particular patient, it stands to reason when you cut that carbohydrate intake strictly way down and keep them at a carb ceiling of 25 grams carbs every 4 hours or less, what you'll see is that LDLP and that ApoB come drastically down, even if you didn't use the statin. There's one patient that I may show you later in this presentation that was on 40 milligrams of Crestor, and when he had a problem with taking Crestor and a myopathy developed, we ended up having to treat him without statin therapy for a while, and I was able to get his LDL-C and his LDL-P lower without the Crestor than when he took the Crestor, because at the time he was taking the Crestor, he was actually overeating carbs. He didn't know the ceiling. When you cut that ceiling down, you can make such a difference. Now imagine if you cut down the carbohydrate intake and you also are capable of using a statin because of no issues. Now you're going to get that LDLP, ApoB down to a good number. Where do I usually see LDLP and ApoB for plaque regression? My goal for patients is getting an LDLP less than 900 and an ApoB less than 50. If I can achieve both of those goals, in most cases I'll see plaque regression if I control the inflammation. So inflammation plus controlled cholesterol, that's the recipe for removal of plaque. And it turns out when they data mined my office over an 8-year period, I had approximately 73% reduction. Our patients, 73% of my patients that had evidence of plaque regression based on plaque leaving through the carotid Doppler with intermedial thickness measurements. The next 4 biomarkers I want to discuss with you have to do with the HDL products and how they correlate with what's going on with insulin resistance. We talked about this earlier, but HDL tends to shrink because it loses cholesterol, gains triglycerides, and you urinate and lose this product as a person becomes more and more insulin resistant. Thus, the HDL-P is going to decline as a person becomes more and more insulin resistant. The HDL-2B, which is a subfraction of the HDL-P, ApoA1, that is the lipoprotein that sits 1-to-1 on top of the HDL lipoprotein. So if you're losing HDL lipoprotein, you're going to lose ApoA1 with it. And also the ApoB to ApoA1 ratio, bad cholesterol to good cholesterol, that ratio is going to expand when a person becomes more and more insulin resistant. When you see patients with any one of these 4 turning into the yellow or the red zone, meaning bad or real bad levels of both of any one of these 4, that patient is insulin resistant until proven elsewise. In my experience, when you see these things shifted in almost every case I've ever tested in a 2-hour glucose tolerance test, they have been abnormal, meaning that their 2-hour glucose has been greater than 100. If a glucose taken 2 hours after a glucose tolerance test is between 100 and 140, it is abnormal, called insulin resistance syndrome. If it's between 140 and 200, abnormal, in this case is called impaired glucose tolerance, and greater than 200 by definition is diabetes. Now I will tell you, I personally don't believe in pre-diabetes. I believe pre-diabetes is kind of like pre-pregnancy. You know, you're either pregnant or you're not pregnant. You're either diabetic or you're not diabetic. I think a lot of well-meaning physicians years ago drew a line in the sand with these numbers, called this pre-diabetes, called this diabetes. However, we know so much more about diabetes now than we did at that time, and we realized that patients with pre-diabetes have all the same cardiovascular developments that people with full-fledged diabetes have. Thus, how can you differentiate between the two? If they all have heart attacks, they all have strokes, they all have small vessel disease such as peripheral neuropathy, chronic kidney disease, or retinopathy. Thus, you can believe how you wish. I just explained the parameters, but these patients, if you see a shift down of ApoA1, HDL2, HDL-P, or you see an increase of the ApoB to ApoA1 ratio, any one of those 4 changes, almost every instance I've ever seen has been a patient with an abnormal 2-hour glucose tolerance test, an insulin-resistant patient. Sterile stanol testing. This is a form of testing that basically helps you understand what's going on in the cholesterol status and where it's coming from, how to adjust your treatment, and how to maintain your treatment. You see, when you look at your ApoB and your LDL-P, you see an elevation here in this testing. When you look at the sterile stanol testing, you can see that these particular patients in the lower rectangle have markers for their hepatic sterile synthesis, and then you have the sterile absorption markers in the top rectangle that has to do with the fat that's being absorbed through the intestine. In that lower rectangle, if you see both red like you see in this picture, you've got a patient who is hyper synthesizing, making too much bad fat through this liver synthesis process. In this particular case, the absorption through the intestines, through that top rectangle, suggests that everything's in the green, meaning a normal level of fat absorption. Thus, where is this extremely high level of LDL-P and ApoB coming from? And in this case, it appears quite probable it's coming from the liver synthesis. This patient's definitely going to benefit from a reduction in carbohydrate intake and a placement on statins. You've got this next patient. You see the lower rectangle, which represents the sterile synthesis, showing a hyposynthesis patient. This is probably a patient on a statin And this would be a marker that the statin is working rather well, because the statin is blocking the liver from synthesizing more and more bad fat. You see that there's a compensation in that top rectangle, and this is something very commonly seen in approximately 40% of patients who put on a statin. Their intestines become